Thank you very much. Good morning, I'm Michael Smrtka from Northwest Perinatal, and the title of my talk this morning is Gestational Diabetes, Insulin Made Simple. I have no relevant disclosures for this morning's talk. First, I'm going to highlight the updates from the most recent ACOG practice bulletin on gestational diabetes, which was published in July of 2017. And then I'm going to go over some basic concepts for insulin therapy in pregnancy and conclude with some practical tips for managing insulin in pregnancy. Historically, insulin has been the standard therapy of gestational diabetes management when exercise and nutrition modification have not resulted in optimal glycemic control. About 20 years ago, the initial studies on oral agents in pregnancy provided an attractive alternative to multiple injections a day. However, subsequent research has not shown all of these therapies to be equal in their effects and their outcomes. Therefore, if I had to summarize the practice bulletin in a single line, it would be insulin is the new insulin. So ACOG recommends that all patients with gestational diabetes receive nutrition and exercise counseling. And when these fail to adequately manage glucose levels, insulin should be started as the first-line therapy. Glyburide and metformin are now considered second-line agents because neonatal outcomes tend to be worse even if equivalent glycemic control is attained compared to insulin. This means higher rates of respiratory distress syndrome, neonatal hypoglycemia, macrosomia, and birth injury, and neonatal hyperbilirubinemia. Both of these agents cross the placenta and have been found in cord blood, and there are some unknowns about any long-term effects of exposure to these medications in utero. Nonetheless, these agents can still be considered as second-line therapies, particularly in cases where patients decline insulin therapy after appropriate counseling, or if it's felt by the provider that the patient cannot safely administer insulin. Therefore, insulin is the preferred agent for management of gestational diabetes when diet and exercise are not adequate to control blood sugar levels. Insulin does not cross the placenta, and although there are many different types of insulin, they all essentially work the same way by facilitating peripheral tissue glucose uptake. This slide, apologize for this formatting. So this slide kind of outlines the different action profiles of the various insulins. So it compares the onset of action, peak action, and duration. And we can use these different pharmacology principles to try to mimic what the pancreatic insulin secretion is normally doing in order to help control blood sugars in pregnancy. For example, using a short-acting insulin like regular insulin or Lispro is going to cover the meal that we are about to eat. Regular insulin takes about 30 to 60 minutes to begin working, so it has to be administered 30 minutes before eating. Lispro or Aspart work almost immediately, and so it's more convenient to take because patients can give the injections right before they eat. Intermediate-acting insulins like NPH take several hours before they hit their peak effect, so they're useful to take at bedtime to help control fasting blood sugars. And then longer-acting insulins like Glargine essentially have no peak and can be taken in the evening to control fasting blood sugars and will have an impact on blood sugars over the course of the day. So when should we be starting insulin therapy? Well, it's when diet modification and exercise are not controlling blood sugars, and this has been defined as more than 20% of values over the goal, and this would be fastings over 95 or 2-hour postprandials over 120. It's also appropriate to consider starting insulin initially for patients that have a high fasting blood sugar on their initial screening test, because it's very unlikely that we're going to achieve optimal glycemic control with dietary modification and exercise alone. It's also reasonable just to check blood sugars for that patient and then decide. Once we've decided to start insulin, we calculate a total daily dose based on the patient's weight. Insulin resistance increases over the course of pregnancy due to the growth of the placenta and the secretion of hemiplacental lactogen, which decreases insulin sensitivity. And this will be taken into account when calculating a total daily insulin dose. I'm going to go over two of the kind of most commonly used basic insulin regimens on this morning's talk. There are other ways beyond this, but these are far and away the most common and simplest, I think, to use and understand. First, talking about the use of an intermediate-acting insulin like NPH and a short-acting insulin like Lispro or regular insulin. So the intermediate insulin NPH is given in the morning, which is actually covering lunch, and then it's given again in the evening at bedtime, which is covering your fasting blood sugars. The short-acting insulin, regular or Lispro, is given just before breakfast and dinner to cover those meals. This is also convenient because the morning insulins can be mixed into a single syringe, which saves the patient an extra shot per day. So in essence, what happens is that 2/3 of the total daily dose is administered in the morning dose, and the remaining third is administered in the evening. In the morning dose, 2/3 of that is going to be the intermediate acting, and 1/3 is the short acting to cover breakfast. In the evening, half of the total of the remaining dose is given to cover dinner, and the other half is given at bedtime to cover fastings. There are online calculators to help simplify the equation, but this is also fairly simple to calculate on the fly. So as an example, if the total daily dose based on weight for the patient was 60 units, we'd be giving 40 units of insulin in the morning, which would be broken down into 26 units of NPH and 14 units of regular. The remaining 20 units would be given in the afternoon, or rather the evening. And so 10 units would be given before dinner of the short-acting insulin, and then 10 units of NPH at bedtime. In cases where patients only have fasting or only have elevated blood sugars at one particular time point, such as elevated fastings only, and their postprandials are in the goal range, it's advised just to give insulin to cover the elevated blood sugars. So for example, if they have elevated fastings, starting with 10 units of NPH at bedtime can be a very effective strategy, and then titrating as needed. The second most common regimen that we would see would be a long-acting insulin like Glargine or Lantus and Lispro. So about half of that total daily dose would be administered as the long-acting insulin Glargine, and the other half of the total daily dose would be divided amongst meals. So again, in our example of 60 units, for the total daily dose, 30 units would be given at bedtime of Glargine or Lantus, which is going to help with fastings and blood sugars throughout the course of the day. And then you would give 10 units of short-acting insulin with each meal. This is particularly nice for patients that have unpredictable meal times or irregular schedules. For example, if a patient works night shifts half the week, and then on the weekends they have a normal daily schedule, it can be very difficult to tell them when to figure out when to take their NPH and Lispro. So this is a very convenient way to keep a consistent dose throughout the course of the week for somebody that has an irregular schedule. So how to choose the insulin regimen? So as we talked about, NPH and regular are probably the lowest cost option for patients, and compliance is also improved by the fact that there are 3 shots a day. The downside to this is that it's a less flexible dosing schedule. With Glargine and Lispro, this allows more flexibility, but it tends to be more expensive, and it also requires 4 shots a day. You cannot mix Lantus or Glargine insulins with other insulins due to the unique pharmacokinetics of the insulin. So bottom line, there's no perfect regimen for every patient. You have to individualize based on the patient's needs, taking into account their schedule, as well as the affordability, and bear in mind that not all insurance plans cover Lispro and Glargine insulins. Once we've started insulin, I recommend seeing the patient within 1 week to assess their compliance and any barriers to taking their medications. You want to review their blood sugars and see if you were close with the initial weight-based dosing, and titrate as needed. Applaud them on their success if they've done a good job taking all the insulin. I ask patients if they've had the opportunity to forget any doses, which most people do. They're all human. And if they're having issues, particularly hypoglycemia, that's where you want to focus. If they're feeling sweaty, shaky, fatigued, make sure that they're aware to check their blood sugar and treat with a cup of milk, hard candy, or glucose tablets to raise their blood sugar. If you see that patients have actually higher fasting blood sugars the week after you start insulin, it may be that you didn't have the appropriate dose to begin with, or it may be that they're actually having low blood sugars while they're asleep in the middle of the night. And to test for that, you would have the patient check their blood sugars around 3 o'clock in the morning. If they have early morning hypoglycemia, their liver starts converting starch back into glucose to protect them from becoming dangerously hypoglycemic, and as a result, they have elevated fasting. This is known as the Smrtka effect. So the right thing to do in this situation is decrease their insulin as opposed to increasing it. And you want to make sure that they are having snacks between meals as well as at bedtime to prevent hypoglycemia between meals and wide variations in blood glucose levels. Everybody is human, or another way to say this is everybody cheats. And if they have occasional outliers, but the rest of the blood sugars look good, that's, I think, still a successful insulin regimen. You should assess for any clues for noncompliance by looking in the logbook, patients that have frequent missing values or don't bring their book. If all the numbers are the same, or if everything is just below the goal level, I think it can be instructive to check a blood sugar in the office and look at their urine for glucose, because people want to please us, but it might be at their own hazard if they're not checking their blood sugars. If you suspect noncompliance, please do so in a supportive manner and try to focus on the benefits to their baby for taking better control of their glucose, of their diabetes, and also educate them again about the risks of having uncontrolled diabetes in pregnancy. Once you've established a reasonably effective regimen, you should be seeing the patient, reviewing the blood sugar log at least every 2 weeks, and this generally coincides with regular timed office visits at this point in the pregnancy. As we talked about in the earlier slide, increased dosing is expected due to the way that the placenta creates insulin resistance. And so, again, the threshold for increasing the insulin dose would be if you're seeing more than 20% of values above goal or even at the upper limit of the goal range. When you make insulin dosing increases, make sure that they're meaningful. So you want to increase by about 10% at least. So for the patient who's getting 60 units to start, you want to add at least 6 units and allocate those additional units where they seem to be most needed. So if their dinners are really high, but lunch and breakfast are okay, maybe you put 4 units to cover dinner, and the 2 extra units can be to cover those mildly elevated fastings. If they're globally still elevated, and this is kind of your initial look at things, you could be more aggressive than 10%, and it's unlikely that you're going to make them hypoglycemic. It's also fine to do that 2 times over the course of the week as opposed to all at once. So we frequently have patients call in with their blood sugars after a few days just to see if we've made progress on our goal. Recommend using even numbers when you're titrating insulin, since the vast majority of insulin syringe hashes are marked by 2s, and it can be just simpler for patients to be able to draw up to the hash as opposed to trying to aim somewhere in between. For patients that are especially anxious about giving themselves insulin, one thing that can be done to help allay their concerns and show them that it's simpler than it sounds is giving a practice injection of sterile saline while they're doing their insulin teaching. If it's painful or if they're experiencing frequent bruising with their injections, another thing that can be helpful is applying an ice cube to the skin for about 10 to 15 seconds before the injection, which shrinks the surface capillaries and also numbs the skin a little bit. When we're getting into larger doses, exceeding 50 to 60 units, some of that insulin may actually be coming out of the injection site and not being absorbed. So if you're not making progress with blood sugars and continuing to increase the dose, consider splitting that dose into 2 separate syringes so that they're being administered correctly and absorbed. Northwest Perinatal is here to support you and your patients, and we're happy to see any of your patients for consultation. And in particular, if you're having challenges with noncompliance or just having an inability to attain optimal control. In order to be successful in managing patients' insulin and their gestational diabetes, it's critical to have appropriate infrastructure with getting them to dietary education, having staff that are comfortable with insulin teaching, and also sort of a super user for managing refills on insulin and diabetic supplies. Thank you for your time and attention. That was Insulin Made Simple. Are there any questions?